I'm Ann Greiner, President and CEO of the Primary Care Collaborative. The PCC regularly recognizes outstanding leaders from across the nation who are champions for primary care. And today, we're thrilled to recognize Dr. Bob Phillips, Executive Director of the Center for Professionalism and Value in Healthcare at the American Board of Family Medicine Foundation. Welcome, Dr. Phillips.
And thank you. I'm really happy to be here and have uh, have been a champion of the PCC since its inception. So thanks.
Well, thanks, Bob. And we are marking 20 years this year. So we appreciate all of your contributions over decades. So I'm going to start with a table stakes question. Many people in our community know you, but some may not. So help us to understand how you became a primary care champion and really what drives your passion towards strengthening high quality whole person primary care.
Wow, that's taking me back further than I expected. I really thought I was going to be a physician researcher. I started out MD, PhD, and was really looking for some way to combine clinical care and research as I went through medical school. And then I hit family medicine in my third year of med school and did a rural rotation and fell in love with it because I saw the power of relationships in changing people's health behaviors and getting them to adopt the recommendations that were being made for their medications or for other therapies. It was the only place I saw in the healthcare system where the relationship had that kind of therapeutic effect. And it was clear. And I just so then I had to wrestle with how do I marry my interests in research and then in policy with primary care because I didn't have any real role models at the time, but wound up looking for a primary care training opportunity in family medicine that would let me, continue to exercise my research interests and my policy interests. And University of Missouri gave me that kind of an outlet. But it wasn't until the Robert Graham Center opened in Washington, D.C. in 1999, and I came as a scholar that I found a place that had all three of those. And they asked me to come in 2000 as assistant director, and I never left Washington, D.C. I just kept participating in and creating more opportunities for primary care to have a policy impact.
I did not know that history, and that's really interesting. And you continue to practice in addition to doing your research and contributing to all the important policy conversations, both in town, but also across the nation, at state houses and among public and private purchasers. But let me ask you this, because you've practiced, for decades now, and I think you have a sense of what comprehensive whole person primary care looks like and what it doesn't look like. So let's focus on the positive. In your lifetime of practice, when have you been able to provide that kind of comprehensive care, and what did it include?
Well, I want to start by saying I think the question is really important because we're at a point where we're having a generational shift where we have residents in training who don't experience that and therefore don't look for it, don't know what it looks like or what it feels like, and don't fight for it. And that's a real concern for me. I think where I saw this done best in my own practice was a decade ago when we had a PharmD, we had psychologists in our practice, and we really had, and it's a teaching practice, we have residents who are learning there. So it really had a lot of wraparound services where I could have patients sit down with a PharmD and get their medications down from 12 to 9 or 6 or 7, where I could do a warm handoff to a psychologist who could help this patient on their next stage of a journey around mental health and partner with me because they were in the same clinic with me. And those things have been stripped out of my practice, and I mourn that every day
Mm.
because I know what it was like. I knew what it was like to have that. Where I've seen this most fully was in evaluating a Medicare Advantage plan in Texas a decade ago that had been in place for 20 years, was not owned by insurance or private equity yet, and had really dedicated itself to providing that kind of wraparound services. So you had primary care physicians there taking care of 650 patients, as their entire panel.
Mm.
They had hour-long visits. They had health coaches. They had social workers. They had pharmacists. They had community health workers. They really had the full array of comprehensive services for their patients. And they had, well, in our estimation, 60% lower bed days than a peer comparison group of Medicare beneficiaries. But they also had a 50% lower age-adjusted mortality rate. And that was no joke. It really was demonstrating the effect that excellent primary care can give. It made me quite jealous and eager to look for those kinds of models around the country.
Uh, and your career has spanned, a focus on measurement, contributing to conversations about primary care delivery models and payment models and the like. If you had an opportunity to talk to the most powerful people in Congress and in the administration, and you have those opportunities, I know. What is the number one message that you want them to hear about what they should be doing to respond to what I think is a growing concern among beneficiaries and patients of all kinds about lack of access to primary care? And then, as you said, the kind of primary care that we're all advocating for may not be available as it once was. So, what would be your number one message?
Well, my number one message comes from architecture. It's that form follows function. If you want primary care to function in a particular way for particular outcomes, you need to understand what that costs to put that model in place and to support it and sustain it. Our 2021 National Academies report that I had the privilege of participating in said, we can define the model, and we actually had an image of that CMS, to their great credit, picked up and put into making care primary. But we wound up in that model, even though they respected that it has to have a long runway for effect, and we can't hold it to cost expectations in 3 to 5 year increments. I think they underpriced the expectations. So getting the payment aligned with the functions and the outcomes you want is critical. And I think Deb Cohen at OHSU has us fairly close to understanding that payment function relationship. So I want them to understand that so that we can really have a conversation about if this is what you want, are you prepared to fund it in this way?
Well, that really resonates with me because I think we have a delivery model, the patient-centered medical home, and we've had many variants that are very aligned with that model. I think of them as sisters, brothers, and cousins of that model, and yet we haven't provided the investment in that model to really deliver on its promise. And so instead of a full-fledged team, we may have a teamlet, if that. And we also pay in a way, most primary care clinicians are paid fee for service, and that really does not provide the upfront funds so that you can build out your team, the flexibility to deliver care in
Yeah.
different ways depending upon patient need,
Well,
and the time.
yeah. And if you gave me a second choice, this
Yeah.
came up last week in the meeting we were in, it's please figure out how to make sure the money is reaching the frontline clinician.
Mhm.
Yesterday in practice, as I'm hitting the G22, G2211 because of a very complex patient in a coordinated care manner, I had I said, this is not going to help me at all. Um, so making sure that their
You mean
intention,
because you would not actually ever see that payment?
the health system that my practice is part of will see that payment
Mhm.
without any acknowledgement that it should come to me to help support the work that it was
Yep.
intended to.
Yep. Yep.
So CMS is doing, I think, some important making some important changes around their payment model, but they have to make sure that dollar reaches the patient and the clinician caring for them.
Right. And it was different when most primary care was independent.
Right.
Now, the vast majority of primary care works for hospital systems and insurers and, part of other entities that may be supported by private equity. And so As you say, the dollars may not necessarily get to primary care, so that's a challenge. Well, I do think that this notion of making sure form function, I call it, the delivery model and the payment model need to be integrated. You
Right.
can't promote a delivery model without being clear on how you would price all these various services that folks want. Um, because there is no more gas in the tank. Primary care stretches itself in so many ways to deliver care. You know, there are estimates that 25 to 30% of the care that primary care is providing is actually not compensated in the fee
That's right.
schedule. So primary care is already stretching. And so if you want these additional incredible services that are comprehensive and really take care of patients in a holistic way, there's got to be more dollars. And, less than 5 cents on the dollar is woefully inadequate for the kind of care we say we want.
Yeah, the other thing happened to me yesterday is I got a message from a patient. So I'm not seeing them. There's not a billable event. A message saying my GYN thinks I should have a DEXA scan to check for osteoporosis. Can you, but that you should order it. And I turned to one of my partners. I said, this seems to be happening more and more. Why doesn't the GYN order the DEXA scan? And he said, oh, prior authorization. I said, what do you mean? He goes, well, they don't want to manage prior authorization, so they're handing it off to you to manage the prior authorization. And I said, oh my gosh, that's exactly right. So yeah, so none of that was a billable event. I did order the DEXA scan. It's going to come to me out of context. I don't know when I'm going to see her next to talk about it. So that will be a phone call. That's not a billable event, at least not in my system. So it is a lot of work that is needed by patients that we carry. And to the point of the 2013 National Academy of Medicine Engineering National Academy of Engineering report, physicians are routinely asked to do the heroic thing and save their patients from the health system, and it is at their own cost and is a source of considerable burnout. So yes, we have to fix some of that burden.
Absolutely. Well, you interface with a lot of up and coming health policy leaders, a lot of folks in the clinical space that are going to move into um, uh, positions of real influence. And I know your center has a whole bevy of fellows that you are working with, and that's, exciting because they bring a lot of energy and new ideas. But as you reflect on your work with new and emerging leaders, what are the kinds of things that you're communicating to them? What are you trying to imprint on those new and emerging leaders?
Well, it's a few things, and it's one thing I try and communicate very clearly is this is a very intimidating environment, translating research for policy, but these are human beings. So you shouldn't be afraid to just reach out to talk to somebody in policy roles and approach them, at least in their state of career, as a naive learner, that people are very receptive to naive learners and just engage and learn how to have that conversation, see what their interests are. One of our scholars is from Missouri, my home state, and was working on a project looking at what happens when a community loses their general surgeon or their family physician or both, and demonstrating the loss of that dyad does have significant association with increase in mortality. I said, you're from Missouri, and in fact, you're from the head of the Missouri delegation to Congress, his district. Go talk to him. Go talk to his Health LA and figure out how do you communicate this in a way they can hear and act on. And she came back just very excited about, we connected about rural, we connected about increase in mortality in rural areas. That was the message. So I want them to engage and learn what that is like with coaching so they don't step on toes. But I think that's a really important thing because people are afraid at this early stage of career to do that kind of engagement. And then the second thing is just be curious. Be curious as you approach these things. Ask lots of questions. Curiosity is often an antidote to angering someone because you're coming at them with a question. And I think that's a really, and I encourage my residents to do that when they're seeing patients too, is curiosity is such an important antidote to hubris and to screwing up. So I think those are the two things I push on hard.